Good morning, and thank you for having me here today at the Down Syndrome Connection of the Bay Area Empowerment Throughout the Lifespan seminar. I'm so sorry I cannot present live to you. It turns out I cannot be in two places at once. For me, it is still October, so continues to be Happy Down Syndrome Awareness Month. Today, I want to talk to you about transition to adulthood from a pediatrician's perspective as it pertains to issues related to transitioning the medical piece to that of the adult world. Today, I'll ask more questions than give answers, and that's because part of transition is to ask ourselves questions and assess one's readiness for transition, identify areas where we need to focus, and develop short and long-term goals for a successful transition. So let's start by acknowledging that transition is complex. It's a journey, not a one-time event. That is why, if any of you are my patients or have been my patients, you know that I begin talking about that transition process years before it is actually time to transition out of pediatric care. Because we want to think of transition of the medical piece in the context of other areas of transition to adulthood, like where is the person going to live? Who's going to be making important decisions? Of course, we're going to always involve our young adult in our decisions, but who will have the legal decision-making abilities? Um, are we thinking about secondary education? Are we thinking about secondary education right away, or are we thinking about adult school first and then secondary education? Are we looking at employment? What interests the person that might be an area of employment for them? Just like any of us think about what do we like to do? What would we like to do every day that makes us wake up in the morning and be excited to go to work? The same should be true of our loved one with Down syndrome. What are our strengths and aptitudes that can make for successful employment, and what skills do we need to be employable? Or are we looking at day programs? And again, what are some interests and some requirements for what the day program might look like? When it comes to medical care, some aspects of transition will involve finding new providers who can take care of adults and ideally have some experience caring for a person with a developmental disability. And so that search for providers is one part of the transition process. And then other aspects of transition involve preparing our young adult to be more independent with issues surrounding our health. And so talking about that independence with taking care of one's health, it helps to take a step back and ask ourselves the following questions. Does my young adult know what medicines they take and why? Um, this is something I discuss with all my teenagers with or without developmental disabilities. What medicines do you take? What time do you take them? Are you the person who remembers to take them, or do you wait for your parent to remind you? Are there things that we can do to make you more independent with taking medications? So that could be a pill box that someone helps fill out on a weekly basis with the medications. And then we have beautiful technology these days, reminders for when it's time to take medication so that we can partner with our parent and caregiver in remembering to take the medications at the appropriate time. And again, why are we taking these medications is another important thing because it leads to self-advocacy, right? If I know that I take medication for my thyroid, then I know that I need to see a doctor for my thyroid every so often. And I know that I need some blood work every so often to make sure that the dose of my thyroid medicine is still good. Does my child know if they have allergies to foods or medications? Food allergies and medication allergies are really serious issues. And knowing what foods to avoid and knowing what medications to avoid is an important part of taking care of our health. It might take a lot of remembering and repetition and modeling checking labels to review what foods need to be avoided. It can help to have a medical ID bracelet or other reminder of what we are allergic to. It might be that we have an app on our phone, like a health app, where our food allergies are listed, and practicing and modeling checking those lists when deciding what to put on our plate, what to order at a restaurant, and what to put on our plate at a buffet or at home. I think it's extra helpful to model asking, does this plate contain this specific food when ordering at a restaurant? If we are allergic to peanuts and we are ordering fettuccine alfredo, then we're likely to know that the fettuccine alfredo is not going to contain peanuts. However, if we make it a routine to and model, excuse me, might I ask, does the fettuccine alfredo contain peanuts? Then through practice and repetition, we're modeling how to check for foods that might contain the allergen every time. It helps with generalization and it helps with independence. For allergies to medications, again, it is helpful to have a bracelet that lists medication allergies. Many medical ID bracelets will have a code that can be scanned and links with a page that has a variety of health conditions listed. Medical records should include allergies. It might help for you to begin modeling carrying maybe it's an app on the phone that we update regularly that is much more portable than any notebook. But if we're the kind of people who prefer paper, then modeling carrying a notebook and modeling how that notebook is organized. And there is a page for allergies so that if we go to a new doctor that does not have access to our electronic medical record, then we have those allergies listed. And if we're asked, do you have any allergies to medication, we can practice that. For these things, you can partner with your pediatrician too. If you come in as a parent and you tell me, you know what, I'm working with Lisa on reviewing what medications she's allergic to. Do you think you could ask us what medications we're allergic to at every visit? That would be very helpful. I would have no problem doing that, even though I might already know about it and already have it listed in the medical record. Does my young person know how to call the doctor or dentist to make an appointment? Many of us wake up to the rude awakening once our child turns 18 that some doctor's offices will not actually speak to us, the caregiver, anymore, and will request for the young adult to be on the phone, even though our young adult may struggle with communicating over the phone. We'll get to that in a second when we talk about the decision-making piece of it and the legal aspects of it. But it is also helpful for anyone to know how to make a doctor's appointment, whether it's how to make a phone call or how to do it on a health app, like a My Health Online or My Chart type of thing. Whenever you are calling the doctor to make an appointment, even though it's much more efficient to do it when our kid is at school and we have that moment of quiet before everything else starts to happen, if you're working on transition, it's going to be important to actually wait until a young person is home and say, hey, we have to make an appointment with your doctor to talk about your nails. Let's call together, and then modeling how to do that. Many young people have their own cell phones. Cell phones now allow us to list our contacts, but also have pictures associated with it. You might choose a picture that represents the doctor's office, and it might be a picture of the doctor's office itself or a picture of the doctor themselves, so that the young person can have an easy time recognizing the contact and calling themselves through the phone. How do we know when it's time to refill our medication? Well, some pharmacies have us on auto refills and text us, hey, it might be time to refill our medicine. Other pharmacies don't do that, and it's on us to call and ask for a refill. When do we know that it might be time for a refill? When we notice that our pill box only has a few pills left, that should clue us into the fact that, hey, we might actually need a refill. So, how do we help our young person recognize that that means that it's time for a refill. That might be when we're putting our pill box together. It might be that as we open, if we don't have a pill box and we're opening the container each time, we have a script for, look, there are only 5 pills left in the box. 1, 2, 3, 4, 5. This means it's time to request a refill. Who do we call for a refill? And again, having the pharmacy pre-programmed on one's phone. Um, I recognize that some of these tasks can be quite complex, and that it can be difficult even for someone who's not neurodiverse to navigate these complex systems. I also want to recognize that many of our young people with Down syndrome will require support from a caregiver to do these things. And it is still important to empower the young person to become as independent as possible in doing these things and as participant as possible in these processes, because that's just part of becoming an adult. Taking care of one's health also means making healthy decisions for our bodies. So when we think about individuals with Down syndrome and we think about what is common in our people with Down syndrome, one of the things that is quite common is obesity, right? And weight gain and obesity are things that are common and things that can be associated with other health issues that are significant. So it is a very good investment to think about supporting a young person in choosing healthier options for food and for drink, portions, and exercise habits. Our individuals with Down syndrome are strong visual learners. So anything that is a visual or involves visual modeling, like video modeling, is likely to be more effective than just telling someone, hey, don't overfill your plate. It might be that you pick the plates that have dividers as your plate in which you practice portion control, and you have assigned foods for the different parts. And so we put the vegetables in the larger portion piece because half of our plate should be filled with fruits and vegetables. If you've seen the healthy plate model graphic, it looks exactly like that, with half of the plate being filled with fruits and vegetables, and then a quarter having the carbs and a quarter having the protein, and then the drink that's depicted is water. It might be that we think of the menu for the day together or for the week together, and we involve our young person in thinking about the grocery shopping. Eating vegetables is healthy and important. What vegetables might we cook this week? And thinking together with our young person about that and making them participant in the process. I want to give a shout out to the Adult Down Syndrome Clinic in Chicago. They've actually worked very hard to create not just visuals, but also video modeling around all of this, including the importance of fruits and vegetables, what carbohydrates are, what proteins are, portion control, how to serve yourself at a buffet to avoid eating too much. These are available on the Adult Down Syndrome Clinic website from Chicago under videos and then patient education videos. I do have a link also in our Charlie's Clinic website specific to those videos, and I will make sure that as I upload this video on the Down Syndrome Connection YouTube page, I also put those links in the comments so you can find them easily. Because as we know, things need to be repeated often and in different ways for them to be mastered. I also want us to think about how, especially as we are developing transition goals within the school setting, and especially for those young people who will elect to do the 3 years or so of adult programming, these can absolutely be IEP goals. Don't we all have health class in school anyway? And so why can't we have goals around this that are described in the IEP so that we know that in different settings we are working on these types of things? And then I think that part of it is also doing some self-reflection. I hear often from parents, but my kid is now a teenager and they help themselves to the chips. And I suggest, or they help themselves to the soda. And then I suggest, well, why are there chips in the house? Chips are unhealthy. There are an unhealthy snacks. How are we the adults eating and what are we modeling? Because ultimately we can talk until the cows come home, but our kids will do what they see us do and model. And so part of supporting healthy nutrition choices means modeling those nutrition habits. And the same is true for exercise. And instead of saying, well, it's time for you to go and dance for 20 minutes, or it's time for you to go on a walk, if we have a habit of family walks, if we have a habit of family exercise, that is easier to take on. And if exercise is modeled as a healthy habit, that is just a part of what we do to stay healthy. That is just more likely to stick for the young person and become a habit for themselves as well. Having exercise on calendars helps. I find that if a parent tells their kid it's time to go exercise now, then it becomes an argument between the kid and the parent. I don't feel like exercising right now. I want to watch this. I want to be on my phone. And then it's an argument between the two of us. But if it's on the calendar and the calendar says over here that it's that today we're exercising, then take it up with the calendar, and that can actually diffuse some of the very normal and healthy parent teenager disagreements around what we're going to do on a specific afternoon. As we were talking about medical issues and being empowered to understand our medical issues, I want to call our attention to these amazing worksheets that the Children's Hospital of Philadelphia Down Syndrome Program has put together. And I will put a link to where these worksheets can be found in the comments or in the description when I upload this video on YouTube. And I love them because you can fill these out together with your young person, and it includes the diagnosis or the medical issue, the name of the doctor, any medicines that we're taking for it, any equipments or treatments that are needed, and how will I know when to call the doctor. An example might be sleep apnea, and my doctor is fill in the name of the pulmonologist. And the medicine is maybe nothing if we're not taking any medication for sleep apnea. Maybe we are on a nose spray because we also have allergies that make our sleep apnea worse. And then it might be the nose spray that we take every morning. And the equipment might be our CPAP machine. And I might need to call my doctor if my CPAP machine isn't working, or if my mask is broken, or if I am feeling really tired, even though I'm wearing my CPAP machine all the time. And so it's really nice to be able to fill out these worksheets together with our young person so that we can really empower them to know about their health. And also so that these can live in that notebook that I was talking about. And it can be a notebook or it can be something like this, right? That has tabs where you can insert different things. And so you might have a tab for allergies and a tab for who my doctors are, and one for my list of medications and so on and so forth. There's a lovely worksheet that you can do before every visit, and it's best to start it when your kid is still being followed in pediatric care. Because you might have an agenda of the things that you want to talk about, right? Maybe your kid has been telling you about belly pain or headaches, and you know you're going to talk about it. But every time I see a young person, a teenager, with and without Down syndrome, and I ask them, so what do you want to talk about today? The answer is usually, oh, nothing. And then the parent gives them this look. You know this look? You've been telling me you've had belly pain every day. You're not going to talk to your doctor about that? I see this all the time. So I actually think that it's lovely to think ahead of the visit with your young person about what questions you might want to ask and what things you might want to talk about, and create a little agenda for the visit. Another part of medical health includes interacting with healthcare providers. Um, so thinking about what type of assistance does my young person need when going to see the doctor? Some individuals will be able to express themselves verbally and be understood. Others might express themselves verbally and be difficult to understand, and I might rely on you, the parent, to help me understand their speech if it's more difficult to understand. Some individuals have augmentative communication devices and they are able to navigate them independently, while others have augmentative communication devices and require some assistance in navigating the device. Part of the assistance is it might take a little longer for my young person to answer a question. It might take a little longer for my young person to think about what they want to answer to that question, or to formulate an answer on a speech generating device. And knowing about that piece of advocacy, right, translates into teaching a young person about self-advocacy. I've seen patients have a pre-written piece of paper that they hand into the doctor that says, I use an assistive communication device. It takes me a little bit longer to formulate an answer to your question. Please be patient with me as I provide the answer. And that is an immediate self-advocacy moment that someone doesn't need to think about in the moment, but has already been written out. It could also be said with a switch, which are those buttons that have pre-recorded messages, to really, set the scene for, hey, doctor, you're going to have to be patient. This also means that as you're scheduling the appointment, especially as our teens are needing more time to practice these things, you can ask for a longer appointment as you're calling the scheduler or as the appointment is being made. My kid uses an augmentative communication device. It will take them longer to answer. Should this appointment be longer so that there's adequate time for the conversation to take place? Most medical places have adjustments to appointment lengths based on accommodations and disabilities. Has my young person ever practiced talking to the doctor one-on-one? Um, Often the answer is no. Often the answer is no through mutual desire from both the young person and their parent, where the young person wants the adult in the room. I know I'm a work in progress with this too, because if I know that the young person feels more comfortable with the parent there, and I know that they're going to tell me what is going on, whether or not the parent is there, then I might not push the issue and gently invite the parent to leave the room. However, I'm actually not doing what I'm supposed to because the young person should have a chance to practice talking one-on-one. With neurotypical teenagers, when we talk to patients one-on-one, we talk about sex, drugs, and rock and roll. Um, for many younger people with Down syndrome, younger adolescents and younger adults with Down syndrome, it is highly unlikely that I'm going to be at getting any positive answers around, you know, the sex and drugs. But if I don't ask, I'll never know. And also, oftentimes when I start with the one-on-one stuff, I ask about school and friends because I'm not going to freak someone out by asking them about the most private of things one-on-one when the parent is out of the room, right? The first, if we break it down into an IEP goal, then the initial goal is for someone to feel comfortable talking to a healthcare provider without the parent there, right? To feel comfortable talking one-on-one with a provider alone. And so it really might be that the few things that the doctor talks about at first are more neutral, like what do you like to do in your free time? One piece of self-reflection for a parent is, am I answering all the doctor's questions at appointments? And could my young adult answer questions about their health? Sometimes the answer is, yeah, I actually have to answer all the questions. But most often, the young person should and could have a chance to answer the questions first. And then let's flip it around. Is the doctor even looking at my young person with Down syndrome, or are they only looking at me? Are they only asking me the questions, or are they first directing the question to my young person? How can I encourage my doctor to say, hey, we are really working on getting ready to transition to being an adult, and part of it is healthcare. I would love for you to ask your questions to my son or my daughter first, and then I might fill in where I think it's necessary. Practice makes perfect, right? And so if we are always stepping in and always giving the answers, then we're never giving our young person a chance to do it independently. Can our young person communicate, and this is with any available communication support, about pain or discomfort? When we think about when we interact with the healthcare system, it's either for totally routine stuff like our routine physical and our flu shot every year, or now COVID shots every year, or when there's a problem, right? And that problem usually manifests with some sort of body sensation, headaches, belly aches, toothaches, itching. Does our young person have the ability to communicate these things? If so, how do they do that? Some of our young people are more verbal and are perfectly able to tell us that something hurts. Others might have communication impairments and may not be able to talk about what is painful with their words. And can they do it with augmentative communication? Is something programmed in the augmentative communication device around pain? Again, if the school bamboozles you into thinking that this is not related to education, you can remind them that everybody gets health class in middle school and in high school, and that we can absolutely have health advocacy goals in our IEP, okay? You just bring up health class and bring up, oh, so you're saying that we don't no longer have health class in school, because based on what I know, everybody gets it, and does my kid get it? And if not, we should have IEP goals specific to this, right? It might be visuals. A lot of my patients need questions asked in a very specific way. So if I say, does anything hurt? The answer might be everything or no, not at all. But if I say, does your arm where you have a cut hurt? Then they're more likely to tell me a specific answer. So knowing this a little bit about your young person can help you inform a provider on how to best ask questions. Some individuals who have much more significant communication impairments might not be able to communicate discomfort at all with words, and instead you might notice discomfort based on a change in behavior, an increase in self-injurious behavior or self-stimulatory behavior. Knowing that about your young person is going to be important when you think about how to notify a provider that something might be going on health-wise. And while those of us who work a lot with people who with communication impairments will always think about a body thing as we evaluate a behavior change, that might not be true of everybody if they have a different degree of experience taking care of people with developmental disabilities. So it is important to advocate for that. And similarly, changes in sensorium, and by that I mean changes in vision, changes in hearing. What these things tend to happen gradually, and a young person might not be able to communicate, hey, I feel like my vision has worsened in this eye, but instead they may be less interested in watching their favorite shows or drawing or whatever it might be. I have a patient who presented as, we were worried he was depressed, and I think he's depressed also. But it turns out that we made sure that he went back to all the specialties. It turns out he had really thick cataracts in his eyes too, and his vision had significantly changed. And by addressing the vision piece, it actually helped him go back to engaging in some of the activities that he loved, like watching his Disney cartoons. And then this latter question to ask ourselves is a tough one, I think. Does my young person have the capacity to make their own healthcare decisions? And do I have the legal standing to continue to assist my young person with these decisions once they become an adult? So part of it might be that as a doctor makes a recommendation, even when our person is still a younger teenager, for those of you in the audience who have younger teenagers, that we take that recommendation and then we go home and we say, you know, the doctor suggested that we take this powder to put in your drink to help you poop more regularly. What do you think about this? You know, and the kid might say, yeah, sure, whatever, let's do it. And then you might be able to guide them and say, you know, what might be some things you ask yourself about this? You know, one of the things I wonder when my doctor asks, suggests a medicine are possible side effects. Did we ask about that during the visit? And then we want to think about the potential benefits. What are some benefits of taking this medication? Oh, my poop will be softer and I won't see blood on the toilet paper. And making them participate in that process of making medical decisions that for many of us is happening quickly and almost automatically. It is very important for people to have some way of having some decision-making ability to support their young person with Down syndrome as they become adults. The less intense one is called a power of attorney, and anybody can have a power of attorney. You know, my husband has power of attorney over me so that if I'm incapacitated and I cannot make my own health decisions, he's the one who is allowed to make health decisions for me. A power of attorney is an easier document to obtain. It has to be notarized. The person who is giving consent for someone else to be able to make medical decisions on their behalf needs to be there and assent, but it's an easier document to obtain. The other available option to have legal decision-making rights is called a conservatorship. A conservatorship is a more intense step because it states that someone does not have the capacity to make their own medical decisions and other legal decisions, and they are stripped of their rights of making those decisions, and those rights are instead given to one or more people who will be appointed to make those decisions for them. So, you know, it is at times necessary to keep a person safe, and because if they don't have the capacity to make their own decisions. And I do think it's important to present it as the big deal that it is, because not everybody needs a conservatorship. And I think that because we live in a pretty ableist society, we tend to immediately go there because of our own biases instead of considering all the options. I routinely recommend conservatorships for those who clearly need it. I fill out paperwork to support applications for conservatorships. I do not have anything in particular against conservatorship. I think it does keep many people safe. I just want to make sure that it is a thought process to think about it. And ultimately, I'm not a lawyer, and so I tell people to also consult with a lawyer as well as their regional center case manager to think together about what the best option might be for their specific young person. And then just not forgetting about sexual health and remembering that sexual health is health. So questions to ask ourselves include, has my child received any type of sexual education through school or other means? Does my young person understand the concept of private versus public? And what does that mean exactly, right? So a bathroom is private, but different bathrooms are more private than others. The bathroom in our own house is more private than a public bathroom. I can pee and poop in both type of bathrooms, but I should only masturbate in the home bathroom as opposed to a public bathroom. Um, the bathroom is only private if the door is closed and the curtains are down. If the door is not closed, then that bathroom is no longer private. And so really making sure that those concepts of privacy are well understood and reviewed. Does my young person understand the concept of consent? And is my young person ever allowed to say no in other aspects of life? Learned compliance is a real thing for our individuals with developmental disabilities. From early on, they are told what to do and what not to do and expected to do exactly what they're told, even if it doesn't necessarily fit what they'd like to do. We have behavior assessments and behavior plans and positive behavior plans in school. Um, we may have received ABA therapy or other forms of behavior therapy. So we have learned compliance. Many people with Down syndrome and other intellectual disabilities have required assistance for longer with things like diapering and showering. So they may also be desensitized to what it means to be for like the real true privacy, complete privacy, as well as again that need to comply with a diaper change, right? So modeling the opportunity for consent is so important. I do that. I ask for permission before checking the private area. From very early on, I asked the parent for permission and I asked the young person for permission before checking. And I explained why I need to check the penis, the testicles, the vulva, the butt. And if the person says no, I say, well, all right, you have control over what happens to your body. I will not check you today. I encourage you to talk to your parent about why I, a doctor, need to check there, and we will revisit next time. But that is so powerful for that no to mean something. I do that with stuff like the ears. If someone comes in and they don't have ear pain, I often create an opportunity for someone to tell me no and for me to be able to respect it for different parts of the exam. In your day-to-day life, we tell people all the time, you got to do this. It's time to do that. Let's go on that walk, do this, right? But you might say stuff on purpose because you know that you will be able to accept no as the answer. Would you like to come to the store with me? Or would you like to stay home with your sister? I don't want to come to the store. Okay, sounds good. Your body, your choice, And again, knowing that you can say no some of the time, right? Knowing that you can consent to things is important. Um, does my young woman know how to track her periods? Um, some people are wary to use apps in this day and age. You might use um, you know, your phone calendar, and be a little less specific about what you're tracking, or you can use a good old paper calendar if you're wary about what you're putting on your phone. But if I ask you, and I will ask you, when was your last period? It would be helpful if the young person also knew to open up her little calendar and be able to tell me, because that way they can be able to say, oh, look, I expected my period around this time because we're looking together and we can make predictions together, and my period didn't come. Maybe what might be going on, right? And then, does my young person know that they can talk to a safe adult about any issues related to their genitals? If you know the science is clear that individuals with developmental disabilities are at higher risk for abuse, that the abusers are usually people that they know, not strangers. And oftentimes it's uh, framed in ways that promote the keeping of secrecy, right? So is there someone that they know they can trust, that they can talk to about what has happened and is happening with their genitals? And the same is true for any sort of discomfort. Um, the opposite might be true, right? A lot of our young people are so forward and trusting, and they might tell people maybe too freely about what is going on with their vulva, and maybe, even show someone who's not appropriate what might be going on, depending on the person, right? So knowing who to talk to and how to talk about the stuff in a way that is as private as possible is helpful. The same is true for testicles. If your testicles hurt, that is something that the doctor needs to know right away. So if it hurts here, you've got to tell your doctor right away. We need to screen for testicular cancer in our young men with Down syndrome, because it is slightly more common than in those without Down syndrome. So does the person know how to check their own testicles? And if not, is there a very specific adult who can assist with that once a month? And if so, explaining exactly what is happening and why that person is allowed to do that kind of check. So as we're gearing up for that transition, and after I've asked all of these questions as open-ended questions, as we get more specific, it is helpful to make a to-do list, because that to-do list can feel a lot less overwhelming, hopefully, than just all of these questions bouncing around. As far as transitioning specialty care, it starts with knowing what specialists my kid is currently seeing, and then making a plan for who to transition and when. If someone is very closely followed by gastroenterology and they know my kids super well, that might be the last specialty I transition. Versus if they see the audiologist once a year for their hearing checks and, there's not a lot going on, then maybe that's an early one to transition and just have a taste of what the adult world looks like. What medications does my young person take, and who prescribes them? Do I have enough of a supply to bridge through the transition? Or do I need to ask for that kind of bridge until I've landed successfully with my adult provider? What therapies does my young person receive and need, which will be able to continue after the transition? ABA, for example, is covered through insurance until the age of 21. Thereafter, it's no longer covered through insurance. If that therapy is needed on an ongoing basis, then at that point, we would need a plan for transitioning to the regional center as a funder, just as an example. Same with for the few kids with Down syndrome who also get medical therapy unit therapies. Most kids with Down syndrome do not qualify for CCS medical therapy units, but those also end at the 21st birthday. So having a plan for those things is important. How do we get to appointments right now? Do we get there? Do I drive my young person? Do we take transportation together? If my young person is going to go off and live in a setting, a supported living setting, how will they get to their appointments? Do we need to learn how to call paratransit to set it up, or is there insurance? Does insurance cover transportation benefits, and how do we set it up? Is my young person prepared for a health emergency? Do they have a medical ID information stored somewhere that is easily accessible? Perhaps it's a phone. There are health apps that are accessible even in the emergency setting, for example, or again, a medical ID bracelet that can be scanned. Does my young person know how to call 911? If I, the primary caregiver, were to get sick, is there a place where this information can be accessed by a family member? Stuff happens, right? The COVID pandemic, more than anything, has made us all incredibly aware that any of us can get sick and that stuff can happen, right? So, and you know, just like where are all my passwords stored? Um, where is all of this crucial information for taking care of my young person stored so that someone can pick up if I'm temporarily in the hospital incapacitated or something like that. And then when I think about transitioning my care provider, can I put a finger on what I like about my child's pediatrician that I would look like in an adult provider? There may be some things that you really like about your pediatrician, how they listen to you, how they write stuff down, how they are easy to reach when my kid is sick, whatever it might be. And what are the things, what are those things? And did I find them in the first adult provider that I picked? And let's be real, you might pick a doctor and then you absolutely for adults and then you absolutely love them, or you might pick a doctor for adults and you just don't like them, and that's okay too. And then you can switch until you find someone that you do like. This is not a marriage certificate that you get when you pick an adult provider. Is just a start. And did my pediatrician write a complete note to send to the adult provider with a thorough review of my child's health conditions? If not, is that something that your pediatrician could provide upon transition? Again, because this stuff is overwhelming, I love the tools that have been made available by Children's Hospital of Philadelphia, including the from current providers to uh, adult provider checklists, and then a lot of the things that I was talking about, these open-ended questions in a lovely worksheet that you can fill out at routine intervals to kind of understand what do we need to work on? What are some things that are more pressing than others? And then who can help in this transition? The IEP and the individual transition plan that is within the IEP once a person turns 16 are powerful documents. You can advocate for adding goals around health, including sexual health and safety in the IEP. I've seen goals a lot around the young person knowing who they can hug and not hug, and who, what kind of appropriate touches is correct for them to show to others. And not very often have I seen goals that show the opposite. What kind of touch is okay for me to receive, and how do I give consent around that? And so these are just examples of how to look critically at IEP goals. And as I told you, sex ed and health ed are classes that are a part of any middle and high school curriculum. So you should not be getting flack for asking for goals related to these to be in the IEP. And then your regional center individualized person plan, which happens once a year, can include goals and supports related to transition. There are services like Independent Living Skills, or ILS, that are focused on making a person more independent with things like grocery shopping and transportation and cooking and whatever else it might be. And you can ask your case manager if your young person is eligible for the services, and if not, at what time. If your child has CCS and they live in Alameda County, CCS for things like congenital heart disease or hypothyroidism, or whatever other reason they might have for having CCS as a secondary layer of insurance in Alameda County, there is a transition specialist that can help with this transition. I don't know if that's true of Contra Costa County. You can ask your CCS case manager. .transition.org is a lovely website. It has a quiz that you can take on how ready is my young person to transition and what might I need to think about, and lots and lots and lots of resources. And then, of course, putting a plug for our own website, charliesclinic.org. We have a section for teens and young adults, and in there we have thoughts around transition, around sexual health and puberty, and many other things. There's also the adult healthcare guidelines that were released last year, so that you can check them out and have a document that can continue to guide you as far as things that can be helpful for the care of your young person. And so all of these are supports that are available through this process of transition. And I just want to remind you that you got this. Transition is a journey, and some things will feel more pressing than others, and you will be successful. And it may still have some little untucked corners right as it first happens, but you you will be successful. And I want to thank you for your time and your opportunity to for me to talk to you. And again, I will add links. So I'm doing this like YouTube. Uh, the YouTubers and influencers, I will add links to the resources that I mentioned um, in the under the YouTube video so that you can click on the links and be directed to the resources that I mentioned. Thank you so much.